Next, Spencer King and Dr. David Messika-Zeitoun from the Cardiovascular Division of the Bichat Hospital in Paris, France, discuss clinical outcomes of tricuspid regurgitation.
We're delighted to have you visit with us, David, here on ACCEL.
Thank you.
How common is tricuspid regurgitation?
Tricuspid regurgitation is very common. We know that from the Framingham study or the veteran study that this is a very common echo finding. It's also very common when you have ischemic cardiomyopathy or dilated cardiomyopathy. And of course, in valvular heart disease, especially mitral regurgitation, this is a very, very common feature.
So on echo, you might see a little whiff of tricuspid regurgitation, but you're talking about significant tricuspid regurgitation here. So what is the clinical importance of tricuspid regurgitation?
Good point. Tricuspid regurgitation is often associated with ischemic dilated cardiomyopathy or valvular heart disease, and the question which remained was if the tricuspid regurgitation by itself impacts the prognosis. For that, we did a study a few years ago at the Mayo Clinic looking at isolated severe tricuspid regurgitation from patients with a tricuspid flail leaflet. So they have only the tricuspid regurgitation, no other pathology, and we looked at the outcome. And what we found is that isolated severe tricuspid regurgitation impact the prognosis both in terms of morbidity, increased rate of congestive heart failure, atrial fibrillation, and also on mortality.
I think you made the case that most tricuspid regurgitation is actually functional due to heart failure or left-sided disease. Is that correct?
So that's correct. But if you want to evaluate the prognosis of the tricuspid regurgitation, you need to have isolated TR so you don't have confounding factors because of this left side disease. And what we show is that the tricuspid regurgitation by itself is not good.
It's not good. And it's certainly not good combined with left-sided
it's even
disease.
Worse.
Right. So we have no randomized trials, as I understand it, repairing the tricuspid valve or replacing or leaving it alone. But you've come to the conclusion that repairing or replacing the tricuspid valve is of value. So where does that information come from?
So we have a study showing that severe TR is associated with a poor outcome. So from that, we know that we should cure severe TR, especially when you do left side surgery. There is also several studies showing that if you only cure the left side disease and you ignore severe TR, the severe TR does not cure only after the surgery of the left side.
So if you're going to repair it, or are you going to fix it, how do you do it?
Classical surgery for functional tricuspid regurgitation is a simple annuloplasty, so it's a quite simple surgery. So if you have severe TR, you are doing a mitral valve surgery, you should correct the TR. The question is if you have only mild or moderate tricuspid regurgitation. And we have also data now showing that if you do a left side surgery and you have only mild to moderate TR, and if you don't do a tricuspid surgery, over time, you'll develop severe TR in the substantial part of this patient, and this development of TR also impacts the prognosis. So if you don't treat the TR appropriately when you do the left side surgery, you are high risk of severe TR and you have a worse prognosis.
That kind of leads me to the question of timing. Does this mean you should do it earlier rather than later?
When you have isolated severe TR, we know that if you wait for liver disease, intractable congestive heart failure, it's too late. So you have to treat isolated severe TR precocely before the occurrence of severe complication. And these predictive factors are atrial fibrillation and significant right side enlargement. If you do now left side surgery, what we know is that severe TR is one thing, but you have to do something on the tricuspid valve, even if the degree of TR is mild or modest, and based on the most important factor to decide to cure or not to cure the tricuspid valve, or to treat or not to treat the tricuspid valve, is the degree of tricuspid enlargement. The threshold from the new ACCEL guideline, 40 millimeter, measuring in apical fourth chamber, or 21 millimeter per meter square of body surface area.
So the solution is working on the annulus primarily to reduce the annular size. That's helpful. And occasionally, I suppose, there are ruptured cords and other things.
If you have special anatomy, you have to treat. You have a flay on the tricuspid valve, you have to add cord A. But
right.
If you have only functional TR, you can do annuloplasty. And just one thing is that if you wait for severe enlargement of the right side chambers, you may end up with the impossibility to cure the TR with only an annuloplasty, and you have to replace the valve. So if you do that early in the course of the disease, you may avoid to have a replacement, and we know that from several studies that tricuspid replacement is associated with the worst outcomes than only tricuspid annuloplasty.
So I think we got the message very clearly that it can be dangerous, that addressing it before it gets too bad is the right thing. One last question I want to ask you is that some people might consider that since it's secondary sometimes to left-sided disease, what if you take care of the left-sided disease? Does the tricuspid regurgitation get better?
Good point. We have different models showing that if you only cure the left side, there is some degree of decrease of the tricuspid regurgitation, but only treating the left side does not always cure the right side. So if you go for the left side and you have indication on the right side, do it.
Well, these are very important points for surgeons to consider, I'm sure, in all patients who have tricuspid regurgitation, and we congratulate you on this kind of work that's moving the field forward. Thanks for visiting with us today on ACCEL.
Thank you very much.